Welcome to this Clinical Explainer. If you've ever felt the challenge of bridging the gap between gathering raw data in a psychiatric interview and actually constructing a supervision-ready psychodynamic formulation, you are in the right place. Today, we're going to break down exactly how to make that transformation. We aren't just listing symptoms here, we are learning how to look at the whole human being. Here's our clinical blueprint for today. We'll start with clinical data collection, move on to personality organization, dive into the psychodynamic framework, analyze a clinical case, and finish up by writing that final formulation paragraph. Section 1. Clinical data collection. Okay, let's dive into this first phase and systematically extract our 18 mandatory data points.
We kick things off with foundational clinical history. Now, we all know to look for the presenting problem and the precipitating event, right? But here's the key for dynamic psychiatry. You have to look beyond the facts and ask, what is the subjective meaning of that precipitant to the patient? We also need to map out their developmental history, early attachment patterns, and any history of trauma or loss to really uncover the roots of their current distress.
Next, we map out the patient's internal architecture through their intrapsychic functions. Is their identity cohesive or fragmented? How do they handle affect regulation and impulse control under stress? We also have to evaluate their reality testing, predominant defense mechanisms, and superego functioning. Is their superego relentlessly punishing, or is it basically absent? These internal mechanisms completely dictate how a patient processes their everyday reality.
To wrap up data gathering, we look at relational and coping capacities. What are their recurring relationship patterns? How do they regulate their self-esteem? We absolutely need to assess their capacity for mentalization. Basically, can they understand that other people are motivated by their own internal thoughts and feelings? And don't forget to identify their coping skills and inherent resilience, because recognizing a patient's strengths is just as crucial as identifying their pathology.
Section 2. Level of personality organization. This is where we take all that raw data we just gathered and move to the structural assessment phase. And this brilliantly illustrates our structural continuum across 5 key dimensions. We're looking at identity integration, reality testing, predominant defenses, object relations, and affect tolerance. As you can see, a healthier neurotic patient maintains an integrated identity and intact reality testing. But as we slide over to the borderline organization, we start seeing identity diffusion, really poor affect regulation, and primitive defenses. Move all the way to psychotic organization, and reality testing becomes severely compromised.
Now, here is a really crucial distinction you need to make. Borderline personality organization, or BPO, is a broad structural level of intrapsychic functioning. It is not automatically the same thing as the DSM-5 diagnosis of borderline personality disorder, which is just a specific phenomenological checklist of symptoms. For example, a patient with narcissistic or antisocial traits can totally operate at this borderline structural level.
Let's break down a classic mechanism found at this borderline level: splitting. By definition, it's an unconscious process that separates contradictory feelings or objects. Developmentally, it actually originates in the early months of infancy to protect good experiences from being contaminated by bad ones. Intrapsychically, this mechanism actively prevents integration just to avoid massive anxiety. So, what's the clinical manifestation? Well, patients will compartmentalize people as entirely all good or all bad. Take a patient who sees themselves as a pure, saintly figure one day and a deviant the next, with totally flat denial of the contradiction. The clinical implication here is huge. As a therapist, you have to be ready to contain these extreme shifts without reacting to them.
Section 3. The Psychodynamic Formulation Framework. It's time to synthesize our data and personality assessment.
To build a coherent biopsychosocial hypothesis, we use the classic 4P sequence. We categorize the patient's history into predisposing vulnerabilities, the immediate precipitating events that trigger the crisis, the perpetuating factors that maintain the illness, and the protective factors, which are their inherent strengths and resiliencies.
But we don't stop there. We add a dynamic causal layer. We track how early developmental experiences create internal representations. These representations forge a central conflict or deficit, which then triggers painful affect. To deal with that affect, the ego throws up defenses, which unfortunately results in maladaptive relationship patterns, and boom, ultimately the clinical symptom. We're actually using theoretical pluralism here, blending object relations, ego psychology, and attachment theory to map this entire chain. Section 4. Clinical Case Analysis. Let's transition into practice and apply our deductive blueprint to a concrete vignette.
So, how do we build a formulation for Miss A, a 22-year-old whose brother just triggered a psychotic crisis? Get ready to actively think through this step by step with me.
All right, let's look at her brief anamnesis. MA is 22, suffers from cyclic psychotic episodes, and lives a highly isolated existence, mostly just keeping superficial work contacts. Her current crisis was triggered when her exploitative brother moved into her home. Interestingly, she had an identical episode 18 months ago under the exact same circumstances. Biologically, there's a strong family history of bipolar disorder.
Let's reason through step 1. Her main predisposing vulnerability is clearly the inherited genetic diathesis toward bipolar disorder. As for perpetuating factors, her isolated existence and a severe lack of psychological mindedness. She just doesn't have the capacity to observe her own internal state, which totally hinders her from finding better coping mechanisms through self-exploration.
Moving to step 2. The precipitating event is her exploitative brother moving in. But what is the dynamic meaning of that? It's a massive reactivation of relational stress that simply overloaded her affect tolerance. Fortunately, we do have protective factors to work with. She manages to maintain superficial relationships at work, and history shows she responds well to treatment stabilization.
So the crucial point is connecting all this dynamically. The environmental stressor, her brother moving in, applied massive pressure that totally overwhelmed her ego's defenses, which were already biologically vulnerable. When her ego collapsed under the weight of that anxiety and conflict, her reality testing failed, which directly resulted in the psychotic break. Section 5, the final formulation paragraph. Let's synthesize all the structured reasoning into our final product.
Here is our supervision-ready paragraph. It starts like this. Miss A inherited a diathesis toward bipolar affective disorder. Her cyclic psychotic episodes were precipitated by her brother moving in and exploiting her. Notice how seamlessly we just integrated the biological diathesis and the psychosocial precipitant right from the start. And we conclude with, the patient lacks the psychological mindedness for exploratory therapy. Casework is needed to remove the stressor, combined with supportive psychotherapy to maintain defenses. We basically took our dynamic understanding of her deficits and translated it directly into a highly practical, tailored treatment plan.
Which leaves us with this final provocative question. Does your next psychiatric interview uncover a simple list of symptoms or the dynamic blueprint of a human being? Mastering this isn't about memorizing theoretical jargon. It's about truly seeing your patient through an integrated biopsychosocial lens. Thank you so much for joining me on this explainer, and I'll see you next time.